This is the Think Again podcast. I'm Scott Jentz, your host, and today's episode is titled, Be a Primary Care Retina Optometrist. Our guest is Dr. Ceclia Koetting from the University of Colorado School of Medicine, Department of Ophthalmology in Denver, Colorado. She focuses on anterior segment and ocular surface disease, neurooptometry, and perioperative care. She's also a nationally recognized speaker and content creator, and I'm grateful to have her here. Dr. Koetting, welcome to the Think Again podcast.
Hi, thank you for having me.
Yeah. You've been very involved in sharing insights with fellow ODs about advancement of all kinds of care, including retina disease. Tell us about your views about how optometry is really becoming more capable of managing retinal patients, like those with geographic AMD. It's time for us to step up, I think.
Yeah, I do too. Obviously, we know at this time, we're not doing anything as far as in relation to treatment, but there are how many doctors that are out there that are working in clinics with retina, in retina clinics that are optometrists, right? And as are extenders. So what education do they have? Same one we do, right? And a lot of times the same types of technology in our clinic that we do as well. And so while we may not be directly making the decision or doing the treatment, we can really be a big part of the journey for these patients. And we already are. I think just maybe we don't realize how much we're seeing or that we actually are part of it, or maybe are not just undervaluing our involvement, but actually underplaying our involvement with these patients.
Yeah, I mean, you're in a university setting, and there are friends of yours, I'm sure, that are in the retina department working with the retinal ophthalmologist. And I don't want to critique our colleagues too hard, but do you have a sense that when patients get referred in from our practices that we are undermanaging things that we're otherwise capable of measuring?
Yes, I think that for the most part, when I see patients, and even when I was doing retina extension, I would see patients that would get referred in who had early AMD that hadn't really, well, at that point was, maybe some geographic atrophy into, mild moderate AMD, but dry, right? And essentially had been sent just to make sure, which, to be fair, there's nothing wrong with that, right? Mm-hmm. There's nothing wrong with saying, hey, I'd like to get eyes on that, and then can you send it back to me? But there's a lot of times where the patients wouldn't end up getting sent back when there really wasn't a need for them to be in a retina specialty clinic or seeing a retina specialist at that time. There's no reason that they need to be in that clinic and couldn't be in our normal primary care clinics, or if somebody's got, just a medical modality where they don't needing treatment and can't be monitored by one of us.
Right. There's nothing wrong with it, but you're making a business point, which is that these patients just get auto recalled or auto established on the retinal ophthalmologist schedule.
And or they end up in both offices, right? And that's not really ideal for a patient either. They don't want to go to two doctors who are looking at the exact same thing and being duplicative. They're paying copays for both doctors. They're not really happy about that. They're not happy about the time spent. So if it's not a patient who is needing treatment, I don't necessarily think that there's a need for them to be in the retina's clinic. Unless, again, you are doing hey, gut check. I just want to make sure that I feel comfortable with where you're at by having a retina specialist look at it to say, yes, you're fine. Go back to your optometrist who will continue to monitor you and then send you back when it's appropriate.
So you've made a point that when managing dry eye disease, we should have the right vital dyes. There's things you need, there's instrumentation. And while we have close relationships with retinal ophthalmologists that sometimes have, the next layer of instrumentation, what is kind of the base expectation for a primary care optometrist who is doing, management of retinal patients, maintaining care of them to the point where they need to see the retinal ophthalmologist? Do you have a point of view as to what the table stakes are in instruments?
Yeah, I mean, if you've got fundus photography that has the option for having photos taken, but also making sure that you can do the red free, you can do other types of looking at the photography, fundus photography, OCTs. OCT is really the biggest one. If you've got the ability to do in OCT angiography, even better. But that's really getting to that next level. And even at this point, it's very infrequent that the retina specialist is using fluorescein angiography anymore. They are looking at OCT angiography at this point. They're not doing the injection. So there's not really much that we don't have. I mean, we've got FA, now I'm trying to say autofluorescence. There we go. And we also have OCTs and we have photos. So do they. So there's nothing that we don't have that they do. So again, you can see as much as they are and make that decision of you need treatment because now I'm seeing some leakage. Or if you have the concern, like I said, send them and have them take a peek. But you can also, I'll send actually just my imaging to my retina specialist and say, hey, do you see anything? Are you seeing anything different that I don't? One, that's a learning tool for me, because if he's like, yes, I can be like, well, now if I see that again, I know what I'm looking at, right? But the other end of it is they can also very quickly, because I've got a good relationship, be like, okay, nope, they need to come in. Now it's time for treatment. And I get the patient to them quicker.
And don't be hesitant, my friends, to make a declaration as to what you believe the diagnostic basis is for the patient's image, and put yourself out there to let the retinal ophthalmologist correct it if it's wrong or corroborate if it's right. I think it's a way for us to advance our knowledge. To your point, get reassurance if it is, and if it's not, there's nothing wrong with that.
Absolutely.
Yeah. I think about the importance of communication with retinal doctors, but if we think about OD to OD work, this is another one of those areas where if you didn't have all that instrumentation, somebody in town got an OCTA, you can send the patients to your colleagues for testing, let them bill insurance for that. Patient is a one-time stop, and then the data comes to you for analysis. Do you recommend optometrists leverage their colleagues that way?
Absolutely. So we would do that. So I was working in an MDOD practice in Virginia, Virginia Eye Consultants for almost a decade. And we had a very high referral rate from our ODs in our area. And we worked very closely with them. Many of them didn't have the appropriate tools in their office. So they would actually send the patients just for testing, a couple of them to our office, and then we wouldn't read it. We would send it back to them because there was no need for us to do that. They were managing it. They knew how to. They just didn't have the ability to do the testing in office. So whether it be you've got a good relationship with a group in your area, or you've got an OD that you are friends with and you guys can kind of come to an agreement, I think it's a great opportunity to work together.
Yeah, it's just a really important way to put down the barriers. And listen, folks, every now and again, the patient is going to decide that something about your buddy's practice is more interesting than yours. And so every now and again, they'll make the choice to go somewhere else. It's not a reason to stop doing OD to OD work. The same thing's going to happen with you sometimes. So for the most part, it doesn't. But I love to remind people of that. So thanks. I'm curious, we're here in the first half of 2024. How close are optometrists to delivering medical therapy for geographic AMD?
That's a really good question. I do not think that us as optometrists will be doing the injections. I know that I think there was a study with, I can't remember if it was PAs or nurse practitioners doing injections using an auto injector. I don't honestly foresee that anytime soon, nor do I know that we would go for it. I know that the way that many states' bills are written, we cannot, that is like very definitively put in there as a nope, unless we really overhaul the whole thing, right? And to be honest, I'm fine with that. I don't care. But there are some other treatments that are potentially coming up that are looking at oral therapies. And that I could see us absolutely getting behind as a potential option. We'll see what happens out of that and what other types of things come in the future. But I just don't see that as being part of it. And you know what? I don't know if that's a sword I personally want to die on.
Right.
For getting that. I know that my retina friends who are in the retina clinics are probably like, come on, I watch 1,000 of those a day. I could probably do them. Could you? Yes. Do we really want to fight for it? We're still fighting for a lot of other things. So not,
Fair enough. It's good guidance, right? It's not
yeah,
tomorrow, but the point here also is that our state laws dictate what we do.
they do.
And I know
What we
you agree with me as a past recipient of awards from your state association that we need to continue to support the advocacy efforts of others that are looking to help make sure that if a treatment comes up that maybe in our bailiwick, maybe it's not injectables into the globe, that we're there for that.
Yeah, absolutely.
How should ODs think about scheduling follow-ups for retinal patients? I think it's one of those places where, glaucoma, we have a pretty clear understanding. Dry eye, I think we have a pretty good rhythm, but I don't see retinal patients being referred back as often as they should. Sometimes it's doctors concerned about frequency of services, right? Can I bill another OCT? Not
Bill
sure.
it as long as it's indicated.
Yeah, I mean, do you suggest, following the AOA clinical practice guidelines? Any
What I
other
was about
guidance
to
you
say
have?
is there is an AOA clinical practice guideline, which I don't remember when the retina one was last updated. But I mean, you do need to look at the level of severity of the macular degeneration, GA, whatever you're watching at this point, right? And you need to know how soon you need to see these patients back. For me, my threshold is 6 months on anybody who has it, right? If they've got moderate to severe, every 3 months. And that is mainly based for me off of how I've watched Retina, as well as the AOA guidelines and kind of putting that together. There's also times where it's gut check, right? And it's a, hey, something's not looking right. I'm not loving this. Let's see you back in a month. Let's see you back in 3 months versus your normal 6 because I'm not feeling comfortable. With the advent and with the implementation of more at-home devices to monitor these patients, we've got like 4C Home. That one has been phenomenal. I've caught some patients very quickly transitioning from dry to wet macular degeneration with that. There are different apps on phones. I mean, things that are like that next generation away from using our lovely answer grid, which, nothing better than handing a patient a piece of graph paper and having to really feel a lot of level of confidence in you right there. So I think that if we are implementing those types of things for at-home monitoring, that also can give us a much better idea if a patient's transitioning without necessarily needing to follow them, as closely as maybe we would have before. But again, all of us are different, and I really say that at the end of the day, you have to watch what the AOA is saying, right? And you have to watch what the retina specialists are doing for patients that are in that same level. If you have a retina specialist in your area or a friend who's an OD that's in the retina space, ask them. Because if you are not adhering to what's considered the standard of care, you do end up putting yourself liable. If you are seeing a patient who has severe macular degeneration every year or 2 years, and they change and they've lost vision and they lost functional vision, you are actually reliable and liable for that. So we have to make sure that we are watching them closely enough to make sure we catch any change.
Right. And again, to our colleagues, I mean, if it's an epiretinal membrane with minor macular traction, you might be able to start on a periodic basis. You're not going to find in the guidelines, you recommend we do this every 3 or 4 months. It's based upon the patient's condition. Same with non-proliferative diabetic retinopathy. Be mindful of what the standards are. Give yourself safety. Give the patient reassurance by doing the right tests at the right frequency. I just don't think you can overdo it. I'm not suggesting people bring patients in every month, but I do sense that we're sort of reluctant to see these patients on a regular basis. It's more than once a year. I think that's the general point, and certainly the guidelines say that.
Yeah.
So let's finish with your best advice. We've got, some audience members that are doing a lot of retina care. They're doing coordination of care with a retinal ophthalmologist. There's a lot of us in places in the country where the closest ophthalmologist, much less retinal specialist, is a long way away. What encouragement do you have to give our colleagues a sense of becoming more deeply involved with their retina patients?
Yeah, you have the tools or your friend has the tools, and we all have the education and we all have resources, right, that we can learn, whether that be trial and error of sending it to a retina specialist and having them go, nah, it's not quite what I would call that, and learning from that, or, getting on and really diving into some of these really good resources that we have as far as education, CE that's online now, especially with more talk about geographic atrophy and I had to relearn, what am I looking for? Because before it was, you have it. I don't know how to really tell you more than that because I don't need to, because there was no treatment. We have to stay educated. We need to stay aware, and then we just need to follow through, right? You can have good intentions, but if you don't follow through, it's not going to help the patient. So make sure you're monitoring them. You can do it. We both have confidence in you, right? And you need to have that confidence in yourself and just kind of take the bull by the horns and go with it.
And folks, pay attention in your CE because this stuff is really coming at us fast. And there are some amazing speakers on the circuit, including Dr. Koetting. So great advice. Thank you. And Dr. Koetting, I want to thank you for being our guest on today's Think Again podcast and sharing your thoughts about how to be a better primary care retinal optometrist. Thanks.
Absolutely. Thank you for having me.
That's it for today's Think Again podcast, brought to you by GPN Visions, a peer-to-peer learning community to help grow your eye care business.